Hello everyone and welcome to this 2022 APACI Respiratory Diseases workshop, and this is the second that we have held in 2 years. I would like to thank all of our partners and sponsors for making this possible, and of course all of the speakers that are going to be participating who have generously given their time. There are a couple of housekeeping issues. Firstly, there is a feedback form which you'll find in the lobby. But if you have any questions during the course of the meeting, please use the question tab that you will find in the auditorium. But also in the lobby, there is the Kipler stall, and you can access some of the materials there during the breaks. So the first introduction for the welcome remarks is from Professor Yulong Xu. Yulong is the Executive Director of the Institute of Pathogen Biology at the Chinese Academy of Medical Sciences and the Peking Union Medical College. He is, of course, the chair of APACI, the Asia-Pacific Alliance for the Control of Influenza, and he is a fellow of the American Academy of Microbiology. Dr. Xu finished his PhD studies in 1998 at the Institute of Virology at the Chinese Academy of Preventive Medicine. He was a postdoctorate fellow at the Institute of Gene Therapy at the Mount Sinai Medical School and in the Department of Molecular Pharmacology Medical School of University of California in Los Angeles. So, with great pleasure to ask Dr. Yulong Xu to give his welcome talk. Thank you.
Dear experts, colleagues, ladies and gentlemen, welcome to the second APACI Respiratory Disease Workshop for India. I'm Yulong Xu, the chair of APACI. APACI was formed almost 20 years ago and has a long history of conferences and workshops throughout the Asian Pacific region. Over the last 10 years, we have held meetings in many countries, including Indonesia, China, South Korea, Thailand, Malaysia, Vietnam, Singapore, Mumbai, and of course, India. Today, APACI is working in collaboration with the Association of Physicians India, the India Chest Society, and the Middle East, Eurasian, and Africa Influenza Stakeholders Network to make the respiratory disease workshop for India possible. The meeting will again include contributions from experts from both India and abroad. I'm very pleased that so many of my APACI colleagues are able to participate. Today's meeting will focus on the challenges of clinical practice in India during the COVID-19 pandemic, the new paradigm that have been necessary to adopt, and will therefore be ideal for respiratory physicians, pulmonologists, and infection disease specialists working in the India health system. It has also been designed to make it interactive for medical students and highly relevant for microbiologists and other healthcare professionals. I hope find the informative presented today interesting and inspiring. Thank you and good luck. Over.
Thank you, Dr. Yulong Xu. Very good to hear from him. Now it gives me great pleasure to introduce Dr. Agamvora. Dr. Agamvora has previously been involved in the Department of Chest and Tuberculosis at the R.N. Kupamune General Hospital in Mumbai. He has a very long history of working in these areas. He's been the former associate professor at the Department of Chest and TB at the KJ Somaiya Medical College in Mumbai. He is currently the assistant editor, Journal of Association Physician of India. He's also on the editorial board of Chest India. He is the General Secretary of the Academy of Advanced Medical Education, a past president of the Geriatric Society of India, and a trustee of the Malad Medical Association. And of course, he is the National Secretary of the Association of Physicians of India and is a pulmonologist with many years' experience. So please, I welcome you, Dr. Agam.
Thank you, Keith, for those nice words of introduction, and good afternoon, friends. I'm Dr. Agam Bora. I'm here representing Associations of Physicians of India, and I'm here on behalf of the President, Professor Dr. Shyam Sundar sir. It's my proud privilege to present to you 2022 Conference of Asia Pacific Alliance for the Control of Influenza, that is your 2022 APACI Respiratory Disease Workshop, India, where we are discussing medical practices in post-COVID world, the new paradigms. This conference has academic affiliation of Indian Chest Society and Middle East, Eurasia, and Africa Influenza Stakeholders Association, along with API. That speaks about trust and faith so many stakeholders have in the content and academics of this conference. API was also the academic partners 2 years ago during their previous meeting, and our delegates had scientific feast. And this time, API was left with no choice but to associate with us by popular demand from all my members. I wish all the best for these 2 days of academics, and I'm super impressed with the choice of topics and the choice of excellent faculties that they have. I have no doubt in my mind about success of this event. I urge all delegates to take maximum use of this opportunity. You have the excellent faculties in front of you. Please take advantage of their wisdom and get all your queries solved. You have the chat box in front of you. Put all questions, all queries, all doubts that come to your mind, and I promise to you that the organizers will take utmost care in getting all those solved. I'm sure that the time that you're investing in this conference will go a long way in helping you manage your patients. Would turn out to be the best possible time investment that you've done in some time. Though virtual meeting has its own advantages where we can cross all geographical boundaries and connect with a lot of you, thousands of you in one go, it has its own disadvantages. I lack the eye contact. I lack the opportunity to meet the doyens in their field. I lack the opportunity to meet all of you. But till the time we are able to meet physically, I wish you all a great virtual time. All the best to organizers, and special thanks to Mr. Kim and my close friend, Dr. Rajadhar. Thank you all.
Thank you, Dr. Agam Bora. A wonderful opening message, and yes, we would all like to be able to make eye contact with one another. I think those days will be not that far away, and maybe the next time we have this meeting we'll be able to do that. But in the meantime, we'll continue and we'll work with with what we have available to us. And so the next person I would like to introduce is Dr. Salah Al-Awadi. Dr. Salah Al-Awadi is, of course, representing the MENA ISN, which we have already mentioned, or the other speakers have mentioned them. Dr. Salah Al-Awadi is a medical doctor with a master's in epidemiology at the Ministry of Health in Oman. He currently advises on eradication, elimination, and control of communicable diseases, in addition to the expanded program on immunisation, vaccine supply chain and international health regulations in Oman. He has played a fundamental role in reducing mortality and morbidity of vaccine-preventable diseases for paediatric, adolescents and adult populations. It gives me great pleasure to introduce Dr. Salah Al-Awadi. Thank you.
Everybody, I would like to say good morning, good afternoon, good evening. I'm really honored to extend a warm welcome to you all at the APACI Respiratory Disease Workshop. As associations, we feel it is our obligation to consistently improve scientific quality at these events and gatherings. I will start saying a few words about the MENA ISN, to which I belong and where I serve as a chairperson. The MENA ISN, which stands for Middle East, Eurasia, and Africa Influenza Stakeholder Network. This is a new association that was established recently, sometime in November 2019, with a vision that every country in these regions has a realism and implementation of influenza vaccination program and a pandemic influenza preparedness and response plan in place. Well, the significance of this workshop undoubtedly plays an important role in mitigating as much as possible the health, economic, and social consequences of a potential influenza pandemic and other respiratory diseases is undeniable. Additionally, a wide range of respiratory diseases afflict our community, all of which need to be looked into as well. So I believe in our workshop, we'll tackle those apparently. Along with APACI, the MENA-ASEAN Association Network work to provide countries and professional individuals the tools, updates, and knowledge they need to and required to deal and defend the community from respiratory disease threats as much as possible. As you may see, APACI and MENA-ASEAN associations are example of how the organization envisions working in conjunction with several groups towards tackling of influenza and respiratory diseases as a whole. To accomplish our aim in these 2 days workshop, you are going to have a very enjoyable and productive discussions. In addition to that, we will revisit the most current global regional influenza disease updates, as well as the pertinent revisions to the respiratory diseases and their implications. We anticipate that this workshop will evolve and become more dynamic as much as possible and interactive, allowing each of you to actively participate and enjoy each part and each session of this workshop. The event will also provide a range of viewpoints and experiences on how to approach respiratory disease-related difficulties in the most informed way. By this, I would like to express my gratitude to all of you for your presence today and wish you the best and enjoyable workshop.
Thank you, Dr. Salah. Wonderful to hear from you, and for those that welcome message, I think you've explained to our audience very well what we are hoping to achieve, and I think that now takes us through to our first session, which is respiratory diseases management and vaccination. We have with us the first speaker in this session is Dr. Meen Durasu Tanriova. Professor Meen graduated from the Hacettepe University Faculty of Medicine in the year 2000. She finished her residency training in internal medicine in 2005 from the same university. She has been serving as the consultant of the acute care unit and emergency department for many years. Dr. Meen worked as the co-chief of the Hacettepe University Oncology Hospital and the quality coordinator. Her research area mainly consists of adult vaccination, vaccine preventable diseases, influenza quality improvement, and patient safety. And I am also aware that she has a very high profile in the area of pertussis and has recently been on a number of high profile meetings with that presentation. So without further ado, I would like to invite Professor Meen to give her talk on pertussis. Thank you.
Thank you very much. Dear colleagues, first of all, let me thank the organizing committee for giving me the opportunity to be with you here today. And let me start by sharing my screen. Today, I will be talking about pertussis, in other words, the whooping cough. So first of all, let us just very rapidly recall what a Bordetella pertussis microorganism is. So it's a gram-negative aerobic encapsulated coccobacillus. It's motile and expresses a flagellum-like structure. And here we can see it expresses several proteins, polysaccharides, and toxins, which really cause a damage in the tissue when they invade the human body. So the bacteria strongly attach to the cilia of the respiratory epithelial cells, and they produce toxins that paralyze the cilia, inhibit the immune functions and the ciliary clearance of the host, and causes dermal necrosis and cause inflammation of the respiratory tract, and this interferes with the clearing of the pulmonary secretions. And recent studies also showed that bacteria are present in the alveolar macrophages, so they do not only colonize and infect the epithelial lining, but they also do invade the underlying tissues, and they cause a severe tissue damage through the toxins that they secrete. So, of course, in the pandemic era, we started to talk about the basic reproduction number very frequently. So it's the number of people in an unprotected population who may be infected from one infected patient. And to date, the highest R0, the basic reproduction number for pathogens, is for measles. So measles is a very transmissible disease. It has a very high R0. And now when we are facing the variants of concerns of the SARS-CoV-2 virus, we can see that the BA.5 variant of the Omicron has also reached to a R0 of 18. But just look at this number here. Pertussis is also a very transmissible disease. So we are talking about the new variant, the Omicron, and just recognizing it as a very, very transmissible virus. And when you look at pertussis, it actually has a very high R0, which is very similar to measles and the Omicron virus. So it's a very, very transmissible disease, actually. So it causes endemics worldwide, and it causes epidemics every 2 to 5 years. So you can see a higher incidence of pertussis cases every 2 to 5 years. It's spread by large respiratory droplets, and asymptomatic transmission seems possible, so which is very actually dangerous for immunocompromised people, for people who are prone to the severe outcomes of pertussis, because they can contract the disease just when they're not aware that they're contracting an asymptomatic person. So actually, pertussis affects all ages, but infants are the most severely affected ones. And 80% of the infants with pertussis younger than 2 months actually require hospitalization. So, and they may have a very severe disease course. Actually, pertussis has always been accepted as a communicable disease of childhood. So, a reappraisal article in the Indian Pediatrics Journal just cited pertussis as a 100-day disease over 50 years and discussed about the signs and symptoms and the epidemiology of pertussis among children. But now we really do know that it's not just a communicable disease of childhood. It's a disease of the adults, and it may cause really severe disease and outcomes throughout life. So this is a study, a serology study that we have performed in our outpatient clinic. So we have included about 1,300 adult patients over 18 years of age, and just very, very basic, we measured their antibody level against tetanus, diphtheria, pertussis, and measles. And look here, you can see that 90% of this cohort was seronegative for pertussis. So which means that in a daily life, in a routine polyclinic encounter, you can say that every 9 patients out of 10 are negative for pertussis antibodies. So they need the booster doses for vaccination. And when you look at the epidemiology of pertussis worldwide, actually we have this best surveillance data from Western and Northern Europe. So the highest incidence is actually documented there in those countries, in Germany, Netherlands, Norway, Spain, and UK. And here you can see that when you just look at the incidence rates, the incidence rate is higher among children who are 1 year of age and younger. But when you look at the total number, the absolute number of the cases, actually 62% of the cases are above 15 years of age. So actually, when you look at the cumulative numbers, the total absolute numbers, adults consist of a very big proportion of the pertussis cases worldwide. Actually, again, when you look at the risk of hospitalization, yes, we know that patients, infants less than 1 year of age are at an increased risk for hospitalization. But look at this graphics. Here you can see that actually adult patients over 40 years of age, and especially those over 65 years of age, are also at an increased risk for hospital admission due to pertussis. And there are certain conditions that really predispose to pertussis and its worse outcomes among the adult population. So this is a data from the surveillance of USA, and it's I think very valuable because it's a proactive surveillance. So they have a cohort of patients over 65 years of age, and you can see that obesity, diabetes, cardiac conditions, asthma, smoking, COPD, and certain other chronic diseases really increase the risk of contracting pertussis and also the risk of being hospitalized due to pertussis. We know that there is a two-sided relationship between COPD and respiratory infections, and among these respiratory infections, pertussis may have some different characteristics among patients with chronic obstructive pulmonary disease. So there is a certain evidence answering the question between the relation of COPD and pertussis. So could COPD increase the severity and the course of pertussis infection? Some data shows yes. Could Bordetella pertussis colonization or subclinical infection be increasing susceptibility to COPD? And again, there's some data to this question answering yes. Bordetella pertussis may be causing acute exacerbations along with other pathogens that we classically know in COPD patients. And actually, Bordetella pertussis can also be deteriorating the lung functions of the COPD patients. So it's a two-sided negative relationship. And we also have data for asthma patients. And this data is usually from the US and from Australia. And here you can see that, again, in some surveillance studies, you can see that the risk of contracting pertussis, risk of developing pertussis can be increased among asthma patients. And depending on the age of these cohorts, you can see that the risk can be increased approximately 2 times to 4 times among asthma patients. So we can say that adults are also under risk of contracting pertussis, and the underlying conditions, chronic diseases, and especially respiratory diseases, underlying chronic respiratory diseases, may be risk factors for developing pertussis and also for worse outcomes. The clinical course of pertussis, as you well know, is a very complicated course, and it's because it's called a 100-day disease, because it has a very, very long convalescent stage, which is characterized by chronic cough. So the disease usually starts with non-specific symptoms, and no one can differentiate it from another acute respiratory infection or influenza-like illness. And this catarrhal stage usually goes on for 1 or 2 weeks, and afterwards the paroxysmal stage starts. And this paroxysmal stage is actually characterized with these paroxysms of cough and the severe symptoms of pertussis. And the communicable period, the transmissibility, is actually does actually start with the start of the catarrhal stage and can go on 3 weeks after the start of the paroxysmal cough. So it has a long period of transmissibility as well. In adults, actually, the clinical course of pertussis may be atypical. So the difference from the pediatric population is usually the clinical presentation of the disease. So with this atypical course, actually, pertussis cases are usually lately diagnosed, because sometimes we do not even suspect about pertussis. So this leads to a longer disease course and a more infective disease course. And the symptoms are variable with regards to age, vaccination status, prior antibiotic use, and comorbidities. Sinusitis, otitis, insomnia, apnea, weight loss, syncope, urinary incontinence, pneumonia, and even rib fractures due to paroxysms of cough can be seen. And especially in elderly patients, encephalopathies, intracranial bleeding, stroke, carotid artery dissection, these may be some severe and very, very catastrophic symptoms and outcomes of pertussis. And when you look at, again, the surveillance data from the US, you can see that actually, yes, some of these patients present with cough to the hospital, but look at these. Some of these present with chronic obstructive pulmonary disease exacerbation. Some of these patients present with pneumonia. Some of them present with dyspnea and respiratory failure. Some of them just present with syncope. So we should always be suspicious about pertussis when we just face these kind of patients presenting to the hospital, presenting to the emergency department. And let me again give you another example from our surveillance study. We did an active surveillance among patients who presented with acute cough disease in the outpatient clinic and also to the hospital wards. And we have used the PCR test for the detection of pertussis. And at the end of the study, we have detected a 3.5% prevalence of pertussis, because we usually suspect about pertussis in the adult population when we face a patient with a chronic prolonged cough disease. But among patients with acute cough disease, we very rarely suspect about pertussis. But look at the patients that we have diagnosed. So you can see that there are people working in the high school probably contracted the disease from the school children. There are people with no underlying chronic diseases. And look at this catastrophic case. So this was a female patient, an elderly patient. She presented to the hospital with gastrointestinal bleeding, and she had an underlying gastric cancer, and she died of gastrointestinal bleeding in the hospital. And later on, we have diagnosed the patient with pertussis in the surveillance study. Probably the paroxysms of cough and nausea and vomiting just caused this intractable gastrointestinal bleeding in this patient, who also has a gastric cancer. And this cohort is from the South Africa, and again they have actively surveyed the patients who presented with some symptoms. And here you can see that there are 3 adult patients in this cohort, and 2 of them are HIV positive, and they are diagnosed with pertussis. And no one has suspected about pertussis at the very beginning. So suspicion is the key. So we always, I think, should ask this question when we face a patient with a COPD exacerbation, with asthma attack, with cough, with respiratory failure. Could this patient have pertussis? So I will very briefly go over the medical treatment. The principle is that the earlier a person, especially an infant, starts treatment, the better is the prognosis. So during the first 1 to 2 weeks before coughing paroxysms occur, symptoms may be lessened if we start the treatment. And considering, we may consider starting antibiotic treatment prior to the test results availability if the clinical history is very, very strongly suggestive of pertussis in a patient who is at risk for severe or complicated disease like infants or pregnant women. And we also know that antibiotics will never alter the course of the disease or the transmissibility at the later stages of the illness. So again, as basic principles, we can say that if you face a patient, a child who is more than 1 year of age, we can start antibiotic treatment up to 3 weeks of cough onset. But if we are seeing a patient, an infant who is younger than 1 year of age, or a pregnant woman, then we can prolong this treatment period to 6 weeks of cough onset. I think the most common population of people that we will see are the patients with asthma, COPD, or immunocompromising conditions, and those are elderly. And in these patients, if we diagnose pertussis, or if we clinically suspect about pertussis, we can have a period of opportunity to start the antibiotic treatment up to 6 weeks after the cough onset. Of course, it's always better to prevent a disease rather than trying to cure it. So we should be talking about vaccination. So we have some principles about the vaccination for pertussis. First of all, we should know that we should employ a lifelong protection strategy from pertussis. So we may use active immunization, we may use the cocoon strategy, we may use passive immunization. So active immunization is of course the protection of the vulnerable person, him or herself. But also we can think about not only preventing the infection, but also ameliorating the disease, the severe outcomes if infection is contracted. On the other hand, we can employ a cocoon strategy for the protection of the newborn infant by vaccinating people around. And we can also use this cocoon strategy in the protection of the elderly, immunosuppressed patients, and people with COPD and asthma. And we can also vaccinate the pregnant mothers to passively immunize the newborns and the infants. Actually, in 1975, a whole cell pertussis vaccine was introduced, and this, of course, led to a sudden drop in the pertussis cases. But later on, this whole cell pertussis vaccine has turned out to have severe neurological side effects. So the vaccination coverage rates decreased and the epidemic pertussis returned. But afterwards, many countries eventually resumed the vaccination with acellular pertussis vaccine. And in 2005, American CDC recommended pertussis vaccination boosters for adults. And in 2012, they have expanded this recommendation to the elderly people as well. Now, CDC and many of the other countries and other immunization committees recommend one tetanus, diphtheria, and acellular pertussis vaccine booster every 10 years to the adults. So it will be your choice. If you can have the vaccine available in your country, you can use Tdap every 10 years. Or if you just have limited access to Tdap, you can use tetanus and diphtheria vaccine every 10 years, but just try to select the first booster dose as Tdap for this 10-year booster strategy. Many of the subspecialty guidelines also adopted this recommendation, and starting 2021, the GOLD guidelines also adopted the CDC recommendation of Tdap vaccination for adults with COPD who were not vaccinated in adolescence, so that they can be also protected in adulthood. And also we have recommendations for pregnant women, because we know that cocoon strategy is not as effective as we hoped. But if we vaccinate the pregnant women, the antibodies that she transfers to the newborn baby can protect the baby until the baby develops his or her own immunity. So the recommendation is using a Tdap every 10 years, of course, in adult patients. But if the patient is a pregnant woman, then one dose of Tdap at 27 to 36 weeks is indicated in every pregnancy, no matter what the intervals of the pregnancies are. Actually, United Kingdom just also has this recommendation for vaccinating pregnant women, but they have this window period for vaccination adjusted in order to also increase the rate of protection among preterm infants. So they recommend vaccination starting from 28 weeks, so that women who also give birth to preterm babies can offer protection to their babies. Of course, we should see the results in cohorts. So can we really protect the newborn babies by vaccinating the mothers? So this is a study from Brazil, a surveillance study again, and here you can see that in darker gray columns are the numbers of pertussis cases less than 1 year of age, and in lighter columns are the number of pertussis cases between 1 and 4 years of age. And here you see that in years, the number of infant pertussis cases has increased dramatically. And they have adopted a mother vaccination strategy, vaccinating the pregnant women starting from 2014, and they have reached out to a coverage of 40% in 2015. And here you can see that even in 1 year, the number of infant pertussis cases dropped dramatically. So vaccinating the women, yes, helps to protect the newborn babies. Of course, there may always be hesitant people caring about some potential side effects of vaccinating a pregnant woman. But again, we have large cohorts, data from large cohorts, telling that newborn babies of women who are vaccinated during pregnancy do not have untoward events or congenital malformations. Moreover, they are protected from hospital admissions, they are protected from gastrointestinal infections and upper respiratory tract infections compared to the babies who weren't exposed to Tdap vaccination in utero. So of course, we should also consider pertussis in the context of the pandemic, because we know that the social precautions just prohibited the circulation of other pathogens aside from SARS-CoV-2. And of course, this will have a marked impact on pertussis transmission because people who did not contract the disease in the community will lose their immunity as well. And meanwhile, the vaccine coverage rates for pertussis containing vaccines has also declined. And we may have some difficulties in differentiating COVID and pertussis because they may both present with severe cough disease. Continued microbiological surveillance is so much important in the time of the pandemic because we have a treatment for pertussis, we have vaccination opportunities for pertussis as well. So we need to see if a surge is happening. So vaccination is even more important in the face of waning immunity. So in conclusion, I can say that pertussis is a lifelong threat. Adults can contract pertussis even though they have completed their childhood series or had contracted the disease before. And we should adopt a booster vaccination strategy for a lifelong term, which can protect the individuals and the people around them, and also the people in them, considering the pregnant women. So I thank you for your attention and patience. Thank you.
Thank you, Professor Mean. Excellent talk, as usual. So thank you for that. And look, I just would like to advise everyone that we're going to change our plans a little bit. We've just had a couple of situations. Unfortunately, Dr. Salah has been called away to a family emergency, and Dr. Randeep has been caught up in hospital emergency. But don't be concerned, because we have it all covered. And I'm now going to hand the chair over to Professor Mean, and we're going to then continue with the presentations, and there'll be a couple of surprises in there. But for now, I hand the chair over to the very competent, capable Professor Mean. Thank you.
Thank you very much for your very nice and kind words. I'm honored to be hearing them. So now I would like to present my dear colleague, Professor Parvez Kul, who will do the next presentation. So Professor Kul is a professor of pulmonary internal medicine, and he's a director at SKIMS Srinagar, and he's a very renowned scientist in the field of influenza and vaccination pulmonology, with more than 400 publications and more than 300,000 citations. So his interest lies in respiratory infections, airway disease, influenza, and viral infections. And I'm very honored to be working with him in MENA-ISN, as he is also the vice chair of MENA-ISN. So now I will welcome Professor Cole to make his presentation on pneumococcal vaccination and to see what are the new paradigms and insights about the pneumococcal vaccines in this pandemic era. So Parvez, please, over to you.
Good afternoon, and thank you, APACI and the Indian Chest Society, MENA-ISN and API, for having me as a part of this symposium on respiratory infections. I've been tasked to talk on pneumococcal vaccines. And as we know, pneumococcal disease is caused by gram-positive Diplococcus streptococcus pneumoniae, which has a polysaccharide capsule that serves as an important virulence factor, defines the serotype, and there are nearly more than 90 serotypes known, which vary in terms of their distribution globally and also vary in terms of their distribution according to the age. Each one of them is not equally pathogenic, and nearly 27 of the serotypes account for more than 90% of the most frequent isolates. So the polysaccharide capsule prevents mechanical clearance of pneumococcus by mucus excretion, inhibits the phagocytosis, and restricts autolysis and reduces antibiotic exposure. This was the data from the Global Burden of Disease study, where we looked at the estimates of global, regional, and national morbidity, mortality, and etiologies of lower respiratory tract infection in 190 countries between 1990 and 2016. And we estimated that in 2016, nearly 2.3 million deaths occurred as a result of lower respiratory tract infections, and of these, 1.18 million were contributed to by Streptococcus and pneumoniae. So it's a very important cause of bacterial the world over. In the US, in 2017, more than 100,000 patients were admitted with pneumococcal pneumonia, and in 2019, around 30,000 patients with invasive pneumococcal disease were seen, and nearly 10% of them died. What's important is that 40% of these were seen in adults aged more than 65 years of age, and nearly half of them were also seen in adults between the ages of 19 to 64 years with risk-based indications, which means the bottom line is that more than 90% of the current adult invasive pneumococcal burden is in persons aged 19 to 64 years with risk-based conditions and those who are aged more than 65 years of age. In India, we looked at the Streptococcus pneumoniae as a cause of community-acquired pneumonia in adolescents and adults. It was a systematic review and a meta-analysis done a few years back, and of the 1,435 patients that were included from various stages, the pooled proportion of Streptococcus pneumoniae as a cause of community-acquired pneumonia was 19%. Subsequently, another study demonstrated in North India that those patients who were admitted with community-acquired pneumonia, of the 25 patients who were admitted from January 2012 to July 2014, nearly 30% had Streptococcus pneumonia as the major cause, major etiological agent. Shifting gears a bit, we talk about a chronic respiratory disease that's very common, that's chronic obstructive pulmonary disease, the prevalence of which has actually increased significantly from 1990 to 2016 in India, and we have seen that in 2016 around 55 million people had chronic obstructive lung disease, with an increase in prevalence from 3.3% to around 4.2% during the period of 1990 to 2016. The life course of a patient with COPD is punctuated with multiple exacerbations, and if you look at the mortality of patients who survive an exacerbation, it's around 40% at 2 years, which is worse than most of the famed conditions like acute myocardial infarction and the like, which have attracted a lot of attention by the researchers. And a significant number of the exacerbations are caused by Streptococcus pneumonia, and in this certain case, it's 10 to 15% of exacerbations are caused by Streptococcus pneumonia, a reason for us to intervene. And we know that vaccinations have been one of the most important public health interventions in reducing the percent morbidity as a result of multiple diseases, be it smallpox, diphtheria, poliomielitis, and we have achieved near elimination of some of these diseases as well. And as a result of the global high burden of pneumococcal disease, World Health Organization considers that prevention of pneumococcal disease is a high priority area for all geographies, be it industrialized or developed countries. This is the current pneumococcal and the new pneumococcal vaccines that are available, that are mainly divided into polysaccharide vaccine or the conjugate vaccine. The polysaccharide vaccine is made of the capsule polysaccharide. It evokes a T-cell independent immunological response, which has no production of memory B cell production. Whereas in the conjugate vaccines, the capsule polysaccharide is basically conjugated to a non-toxic diphtheria protein, which is known as the CR197. And as a result of this conjugation, it evokes a superior T-cell dependent immune response with production of memory B cells. So it is a better immunological response evoked by the conjugate vaccines compared to the polysaccharide vaccine. The key vaccine effectiveness has been superior with pneumococcal conjugate vaccine compared to PPSV23, be it the healthy people, be it those with chronic medical conditions or the immunocompromised patients. As you can see that there is a distinct superior response as a result of the pneumococcal conjugate vaccine. The duration of protection for pneumococcal conjugate vaccine is around 15 years. There is no decline for 5 years for the PCV, and then there's a linear decline to 0 over the next 10 years, whereas with PPSV, there's a linear decline from the word go to 0 over 15 years of time. These are the previous ACIP pneumococcal vaccine recommendations, which are actually current in most of the countries in the world. If there was none of the conditions listed below, then there is no recommendation for the age group of 19 to 64 years, whereas for more than 65 years, there is PCV or based on a shared clinical decision making, and then PSV3 for 23 for all. Those with chronic medical conditions, PPSV was recommended during 19 to 64 years of age, and for those who were more than 65 years, it was PCV based on PCV13 based on shared clinical decision making, and also PPSV 23 for all. Those with cochlear implants, CSF leaks, or immunocompromising conditions, both PCV and PPSV3 were recommended, and PPSV was recommended to be repeated after 5 years in those who have immunocompromising conditions, and if they were more than 65 years of age, both PCV 13 and PPSV were recommended. So these recommendations were slightly cumbersome and complicated and involved shared clinical decision making. However, based on a number of studies which demonstrated that PCV13 was effective against vaccine type invasive pneumococcal disease, it was effective against the vaccine type pneumonia, it was also effective against the vaccine type disease deaths, and as was demonstrated with PPSV 23 with the pooled vaccine effectiveness of around 38%. And also its effectiveness of around 20 to 34% in patients who had a vaccine pneumonia. So these were the recommendations that were, despite being complicated, despite being cumbersome, were actually adopted by most of the societies in the world, including various societies of physicians in India, be it the Association of Physicians of India, Geriatric Society, Indian Academy of Allergy, and Institute of Nephrology, Mass Gathering Advisory Board consensus recommendations. All of them use the same recommendations, except for the Indian Society of Nephrology, which used the 65 years of age, but all others have used 50 years as the cutoff for initiating pneumococcal vaccinations, as against 65 years in the previous ACIP recommendations. We at the Indian Chest Society and the National College of Chest Physicians had Indian consensus-based recommendations for pneumococcal vaccination. Again, we recommended the same vaccination, putting the cutoff of 50 years of age as against the 65 years. However, there are a number of challenges to the current vaccination strategies. We have only a subset of the 100 serotypes that are being targeted. Then there is emergence of non-vaccine serotypes and unencapsulated Streptococcus pneumoniae. There may be an inadequate protection against capsule serotypes which are not included in the vaccine. Then antibiotic resistance of the bacterium, as well as those of the non-vaccine serotypes, is a problem. There's an inadequate surveillance of disease burden serotypes, specific epidemiology in developing nations. There may be a low immunogenicity of PPSV in the very young, and cost effectiveness. So the impact of use of pneumococcal conjugate vaccine in the United States to date has been there has been a reduction in the vaccine type, that is the PCV13 type. Pneumococcal pneumonia PCV13 type invasive pneumococcal disease was observed after its introduction in those aged more than 65 years of age. And however, the most common remaining PCV type disease is due to serotype 3. This was a very fascinating news that came in June last year, when FDA approved Pfizer's Prevnar 20, which is the pneumococcal conjugate 20-valent vaccine, after it was found to be non-inferior to the PCV13 after having been tried in 6,000 adult patients 18 years or older, which included those with 65 years of age or older, vaccine-naive adults, and adults with prior pneumococcal pneumonia. It was found to be non-inferiority to PCV in phase 1 randomized controlled trial. Although in 2 randomized controlled trials, it was found to be less immunogenic, though the clinical relevance of that less immunogenicity in 12 to 13 of the shared serotypes was not defined. It was non-inferior to PPSV3 and was equally effective in the age groups of 50 to 59, as well as those between 60 and 64 years. There was no evidence of serious vaccine-related adverse effect as compared to PCV13 or PPSV23. Subsequent to this, another month later, there was Merck announced US FDA approval of their pneumococcal 15-valent conjugate vaccine based on their trial of using this in around 7 randomized controlled trials of healthy adults 50 years of age or older, adults 18 to 49 years of age, with no history of pneumococcal vaccination, which included individuals at an increased risk of developing pneumococcal disease, adults living with an immunocompromising conditions like the HIV, and then as a part of the sequential program with PPSV 23, and it was found again that it met the non-inferiority criteria for the shared vaccine serotypes, whereas it had a superiority over the PCV had a superiority over the vaccine serotypes that were not a component of the PCV13, and it was found again to be non-inferior to the PPSV for the 14 of the serotypes that were shared, and it was equally immunogenic. No severe side effects were reported as compared to the PPSV or the PCV13. If you look at the proportion of invasive pneumococcal disease caused by serotype groups in adults aged 65 years or older, around 27% of the serotypes are covered by PCV13. Another 15% are covered by PCV15, but they are non-PCV13. And if we have PCV20, around 29% of serotypes are additionally covered, which are not covered by PCV13. And if you look at invasive pneumococcal diseases in adults aged between 19 to 64 years with risk-based indications, then, for example, in those with chronic medical conditions and immunocompromising conditions, it varies between 25 to 32% with PCV13, and additional 12 to 14% occurs with PCV15, which are non-PCV13 type, and an additional 28 to 29% with PCV20, which is non-PCV13%. So if you look at the proportion of IPD by serotypes in adults of 19 to 64 years with risk-based indications, overall there is an increase if we add to the PCV20 the PPSV, 15% for those with chronic medical conditions, and around 12% with those who have compromising condition. And if we give it to those people who are aged more than 65 or above, additional serotypes contained in PPSV23 would confer an additional protection to around 8%. So based on these data and the current recommended options for age-based recommendation for pneumococcal vaccine include that in chronic medical conditions or cochlear implants, the current policy of PCV13 based on shared clinical decision making and a PPSV23 for all. The proposed policy now is that we replace it by PCV20 or a combo of PCV15 and PPSV. And same for cochlear implants and immunocompromising conditions. We usually the previous recommendation was PCV13 and PPSV. Now the current recommendation is either PCV20 alone or a combination of PCV15 and PPSV23. And similar recommendation is for those who have a risk-based recommendation for pneumococcal vaccination, be it a chronic medical condition or those who have cochlear implants or immunocompromising conditions. So PPSV23 alone or PCV13 and PPSV23 or both PCV13 and PPSV23, which were to be repeated after 5 years, were the recommendations earlier, and currently these complicated recommendations have been actually replaced by PCV20 or a combo of PCV15 and PPSV23. So essentially in adults more than 65 years of age or those who are 19 to 64 years with risk conditions and are pneumococcal naive, you either give you give a combo of PCV15 and PPSV23, keeping a gap of about a year with a minimum gap of 8 weeks amongst those who have a possibility of CSF leaks, cochlear implants or bacteremia, then or immunocompromising conditions, or you can give PCV20 alone. And it was not without controversies. The advantages of using PCV20 alone are that it is acceptable, feasible to implement a single vaccine option. It's cost effective, resulting in lower cost and better health outcomes compared to current recommendations, and is expected to provide better protection for the serotypes covered by PPSV23 alone. That is disadvantage, however, that it is the clinical significance of the lower immunogenicity versus PCV13 is unknown, and losing protection against PPSV23 is there, non-PCV serotypes is there. There is no data in immunocompromised conditions for PCV20. Then the advantage of the combo is that it provides a broad serotype coverage. Age-based use at 65 years was cost saving according to CDC's cost effectiveness data. The disadvantages again are logistically it is more challenging to administer the combination compared to a single dose alone. We need to know the vaccination history to correctly complete the series, and this can result in a lower serotype coverage if series is not completed. Again, there was a controversy about getting the age to 50 versus 65 years. Those in favor of age-based at age to 50 years said that you might be able to reduce the disparity in disease burden in adults aged 50 to 64 years of age, may provide more opportunities to vaccinate adults before they develop underlying conditions. Whereas those who were in favor of keeping the 65 years cutoff, they say that the potential for waning immunity makes it favorable to vaccinate later in life when the risk of disease is obviously higher. How it has been demonstrated to be consistent cost saving and cost effective analysis, and still provides an opportunity for higher PCV coverage in adults versus. So concluding, ladies and gentlemen, the new paradigm for pneumococcal vaccines is that we have a simplified option of using either PCV20 alone or a combination of PCV15 plus PPSV23, whether it is age-based recommendation or the risk-based indication. What is also relevant to mention is that these vaccines might not be available in most of the countries. As such, we have to resort to the previous vaccinations only. Adult vaccination has not taken a significant root in India and is not one of the preferred recommendations by the Ministry of Health and Family Welfare as a part of the national immunization program. So it has got to be rolled out. We have to have efficacy and effectiveness data in India, which is unfortunately not available. We don't have routine surveillance data of various serotypes, which would determine which is the preferred vaccine that we could be rolling out in India based on evidence. Then newer vaccines which need to be rolled out from India. We already have a rollout of PCV10 by the Serum Institute, but higher valent vaccines might require to be rolled out depending on the surveillance data that is collected. Then we know that multiple valent protein vaccines and hybrid vaccines may be the future of pneumococcal vaccines. That I thank you, ladies and gentlemen, for your kind attention.
Yes. Dear Parvez, we thank you a lot for this excellent talk and giving us the insights and the focus for the improvement of both adult vaccination and pneumococcal vaccination in India. And now, ladies and gentlemen, I'm happy to announce that Parvez is so kind to take over for an influenza talk as well. So Parvez will be presenting now. He will go live, technical team. Yes. So he will go on with his talk, and now he will focus on influenza and the influenza issues in India. So Parvez, over to you again. Thank you.
Thank you, Mani, for that kind introduction. And I have to chip in for Dr. Andeep. I'll be talking briefly about influenza in India and what is right. And This is the infamous photograph of the 1918 pandemic of the Spanish flu, which was reported to have claimed 50 to 100 million lives. And if I tell you that the one country, despite it being called the Spanish flu, the one country that was worst affected in the pandemic 1918 was India. Nearly 15 million perished in a short span of 1 year and was the single worst affected country in terms of total mortality. Influenza in India, there has been a limited data prior to 2004, and then there were data restricted to pandemics in 1781 and 1918 and 1889. There was a National Influenza Center at the Pasteur Institute in Kannur, which collected data from 1950 to 57, and then the data was specifically concentrated around few outbreaks and pandemics. And subsequently, in 2004, there was a corporate agreement signed between the CDC of the USA and the Indian Council of Medical Research, New Delhi, for a strain surveillance of influenza in the country. And based on their surveillance, they looked at the dynamics of influenza seasonality at sub-regional levels in India, and also looked at and demonstrated that influenza is circulating in various surveillance sites in India, and the positivity of the samples range from say around 10 to around 18% in Kashmir, and overall prevalence was around 14% of the samples that were collected. And the circulation patterns were slightly different in different regions of the country. I'm going to come to that subsequently. In India, that is in the northern part of India, in Kashmir, we demonstrated that pandemic and seasonal influenza viruses were causing acute respiratory illness in Kashmir. There's the northernmost part of India, and we demonstrated that it exhibited a pattern which was similar to the northern hemispherical countries. And then subsequently, we also demonstrated that there was an outbreak of influenza B in an isolated nomadic community in Jammu and Kashmir. There was a resurgence of the H1N1 in 2012-13 in Kashmir, and subsequently we demonstrated that there was a seasonal pattern to the circulation of influenza in Kashmir, which was more akin to what was prevalent in the northern hemispherical, North American or the Western European countries compared to what was there in the rest of the country. And we demonstrated emergence of a new clade of H1N1 influenza virus in 2015 outbreak, causing a severe outbreak. Was influenza as cause of microbial etiology of pneumonia? We demonstrated it, and after doing routine influenza testing for patients with community-acquired pneumonia, and we demonstrated that after Streptococcus pneumoniae and Legionella pneumophila, influenza was the third commonest isolated etiological agent in patients with admitted community-acquired pneumonia. So etiological agent in influenza takes a precedence in management and prevention. Shifting gears a bit, we talk about burden of obstructive lung disease. This is in Kashmir, continues to be one of the sites of the burden of obstructive lung disease initiative, the board initiative, which is run by the Imperial College London. And we have demonstrated that prevalence of chronic airflow limitation is quite high, to the tune of 14 to 19% in people who are aged more than 40 years of age. However, we know that the life course of a person with chronic obstructive lung disease is punctuated with acute exacerbations, and that can be very, very lethal, with 40% of them being dead at 2 years after surviving an exacerbation. Does influenza contribute to the acute exacerbation of chronic obstructive lung disease? We demonstrated in a study of around 499 patients that around 8% of acute exacerbation of chronic obstructive disease was attributable to influenza. So influenza is a cause. What about influenza in people who were going for Hajj and other Umrah pilgrimages? We looked at people, around 9,000 people who were coming from Saudi Arabia during the times when MERS coronavirus was prevalent there. And what we found that often 300 patients who were tested on their return to Kashmir from Saudi Arabia, none of them had MERS-CoV, whereas nearly 33 of them tested positive for influenza viruses. And this was a time when the Hajj was happening in the summer months, and it was not a normal time for influenza circulation in Kashmir. Does influenza cause illness in pregnant Indian women? Yes, we found it leading to we did a study on around 256 patients, and we found that influenza in around 50 patients, 9 needed admissions, and 7 deaths were recorded among the 4 pregnant patients. And one of them, we could actually salvage the child by a post-mortem cesarean section. This is the reason that influenza vaccination is very essential for especially those who are at high risk for complications for influenza, which means those who are at extremes of age, have underlying chronic medical conditions, or will be pregnant during the influenza season, and the healthcare workers. We know that seasonal influenza vaccination can reduce the likelihood of developing influenza, developing a less severe illness, and reduce the likelihood of transmitting influenza from one person to another. It reduces the risk of influenza-related pneumonia by around 60%, influenza-related hospitalization by 50% to as much as 77%, and influenza-related deaths by as high as 80%. However, for whatever reason, despite the fact that we have 5 million people illnesses prevented, 2.5 million medical visits prevented, and 71,000 medical hospitalizations prevented as a result of influenza vaccination, the vaccination uptake is not optimal. And these are the recommendations for people who are to receive influenza vaccination as a part of priority. However, and these recommendations are from the ACIP have not been actually taken up by all societies, whereas in India, till recently, we do not have API, Association of Physicians of India, giving recommendations. The Indian Academy of Pediatric Geriatric Society of India and the FOXI did come up with recommendations, and the Indian Chest Society and NCCP came up with recommendations in 2019, actually published in 2020. And these were the recommendations for adult high-risk groups, South Asian recommendations. But what is the uptake of influenza vaccination in high-risk populations? This is what we looked at in gaps of vaccination usage in patients with chronic obstructive lung disease. And as you can see, in all the sites in India under the board study, be it Mumbai, Pune, or Srinagar, the uptake of influenza vaccine was abysmally low. And same in patients with diabetes, we found that in around 1,100 diabetics, we asked them for whether they were vaccinated for influenza. Only 9% were actually vaccinated for influenza, and those were the ones who had been told by their doctors that they should get vaccinated for influenza. And same was the uptake in pregnant females. We've interviewed around 1,000 pregnant females. 100% of them were not vaccinated, despite them having gotten pregnant during an influenza season. When we looked at the obstetricians who were treating them, 91 obstetricians were interviewed. Of them, only 9 were themselves vaccinated against influenza, whereas 82 were not. Same is the story of another high-risk group, that is patients with heart failure. As you can see, that the total number of vaccinated people is abysmally low. And another high-risk group is the healthcare workers, and ACIP recommends that all healthcare personnel must be vaccinated annually against influenza, and facilities must and are encouraged to provide the vaccine to their staff. But despite these strong recommendations, the uptake of influenza, even in countries like the Western European countries, has not exceeded more than 64% in healthcare workers. We looked at the knowledge, attitude, and practices about influenza vaccination in healthcare workers in India, and we asked them of the 1,400 plus vaccination of the recipients who were interviewed, who participated. We asked them, is influenza a potentially severe disease? A whopping 85% said yes, and they knew that there was a vaccine available against influenza. But despite that, only 4.4% had actually gotten vaccinated against influenza themselves. And we asked them as to whether they believed that the influenza vaccination was safe. Only 83 of 1,400 plus believed that the influenza vaccination was not safe. And when we asked them what were the reasons that they believed that the influenza vaccine was unsafe, they give a variety of reasons. A physician told me vaccine is unsafe. An internet site said that the vaccine is unsafe. I know someone who was harmed by the vaccine. It can weaken the immune system. It can cause joint problems. So there was a lot of disconnect between what they perceived as a safe and an effective vaccine, and then what they actually practiced. Talking of influenza B, we looked at the epidemiological and virological characteristics of influenza B, and these are the results of the Gibbs study. 26 countries, 5 in the southern hemisphere, 7 in the northern hemisphere, and 14 in the intertropical belt. They looked at the correlation between the proportion of influenza and maximal weekly ILI rate in the same season. And as you can see, this is the chart showing the countries that participated in the study. And of the 900,000 plus of around 1 million cases of influenza that was studied, overall median contribution of influenza B was around 22%, and Victoria and Yamagata lineages predominated in 64 and 34% of the seasons. And influenza B, they concluded that influenza B is a common disease with some epidemiological difference from influenza A, and these should be considered when optimizing control and prevention strategies in different regions and reducing the global burden of influenza. What about India? We looked at influenza B in Kashmir as a temperate northern Indian study. We found that there was a co-circulation of the two lineages with northern hemispherical seasonality in Kashmir. And as you can see, in most of the seasons, we have had a co-circulation of the Yamagata as well as the Victoria lineages. And this was a literature review given by Lance Jennings, who fortunately is present. They looked at 15 countries in the Asia-Pacific region, the northern hemispherical countries, the equatorial region, and the southern hemispherical countries. And they reported that there was a significant number of seasons where there was a mismatch between the predominant circulating lineage and that contained in the vaccine. So influenza basically spreads in seasonal patterns. We have a northern hemispherical pattern with a southern hemispherical pattern, and an year-round activity in the paratropical regions. So this is a northern hemispherical pattern with a winter peak, and a southern hemispherical pattern with a winter peak for the winters of the southern hemisphere. And we looked at influenza seasonality at two cities, that is New Delhi and
I think we have a problem with Dr. Ku's internet connection, and yeah. if we are having difficulty to connect Pervez, we can go on with Raja, and then we can have some time to let Pervez finish his presentation and give the conclusions in the Q&A session. So now it's again my great privilege to present you Dr. Raja Dar. So Dr. Raja is the director and the HOD of Department of Pulmonology in CK Birla Hospitals. He has completed his specialist training in respiratory medicine in UK. So he has an experience as a consultant at St. James University Hospital, again in UK. And he was the director of pulmonology at Fortis Hospital in Calcutta. So he set up his first DMB course in pulmonology in Eastern India, and he's also the director of research and education at National Allergy, Asthma, Bronchitis Institute in Calcutta. He has established multiple modules for training of pulmonologists, physicians, technicians, and nurses, with a special emphasis on training trainees and young pulmonologists. And he's a director of Hermes India and successfully completed the first overseas Hermes exam in India twice. So it's my now great privilege to present Dr. Raja Dar to make a speech on long COVID, which we will be facing more and more during this pandemic and probably beyond the pandemic as well. So Raja, please, over to you.
Hello, friends. It gives me great pleasure to be speaking at the Asia Pacific Alliance for Control of Influenza Respiratory workshops being held in India. A big thank you to Mr. Kim Sampson, the Executive Director of APACI, for putting this all together. A big thank you to my colleague, Dr. Pervez Kaul, and a lot of international faculty from around the world for making this meeting a huge success. My topic for the meeting today is to speak about long COVID, the respiratory and the non-respiratory effects. I'll be doing this for the next 20 minutes. This, I feel, is a topic of great relevance given the pandemic that the globe has been going through in the last 2.5 years. So let's try and put things into perspective by defining this condition first. The presentation of COVID-19 has been categorized into 3 broad groups. The first is acute COVID-19, where the signs and symptoms of COVID-19 happen up to 4 weeks. The second category is ongoing symptomatic COVID-19, where the duration of symptoms is between 4 weeks to 12 weeks. And then the last category, which is post-COVID syndrome, where the signs and symptoms develop after the COVID-19 infection. They're not consistent with any other condition, and they continue beyond 12 weeks. And like we said, it's not confirmed or it's not consistent with an alternative diagnosis. The term long COVID has been used to describe signs and symptoms that develop after acute COVID-19. It includes both ongoing symptomatic COVID-19 from 4 to 12 weeks and post-COVID-19 syndrome, which is beyond 12 weeks. So ongoing symptomatic COVID plus post-COVID-19 syndrome equals to long COVID. Can we define the population of people who might get long COVID? There have been some studies looking into this, and I'll put together the amalgamation of what's been discovered in these studies. If you try to define the phenotype of patients, the patients who are at a greater risk of long COVID, it would be patients who are elderly, so increasing age, female gender, increased weight or obesity, background asthma, multiple symptoms at presentation, especially extrapulmonary and pulmonary symptoms, and the British Asian minority ethnic seem to be the group of people who have the greatest propensity to develop long COVID. The patients do not necessarily need a COVID test. And this is important because a large majority of patients, especially going into the latter half of the pandemic, have not really got tested for COVID unless they get severe symptoms. And we'll come back to the percentage of people with mild COVID who might actually get long COVID. Children are not exempt from long COVID, interestingly. Even a smaller cohort of patients studied, but it shows that between the 12 to 16-year age group, there's about 15%, so about 1 in 6 to 1 in 7 kids who will get some symptoms of long COVID, and a smaller percentage in the younger age group between 2 to 11 years. The long-term health problems that we talk about in COVID are not just restricted to the respiratory and the cardiovascular system. In fact, a majority of systems in the body, a majority of organs in the body might get affected with long COVID. So dermatological lesions, neurological, psychiatric lesions, none of these are exempt from long COVID because the denominator, the common factor for all these organ systems, inflammation, is common to all of these organs. We'll come back to what these symptoms and signs entail in a moment. So let's try and probe into the sequelae of COVID-19 in slightly greater detail. There's quite a lot of studies now. They show that it's reasonable to anticipate manifestations based on the symptoms people have during COVID. And this is an Italian study, which I'll quote later. However, the most commonly affected symptoms seem to be the lung, the heart, and the brain. SARS-CoV-19 is expressed across extrapulmonary tissue wherever the ACE2 receptors are present. You know the ACE2 receptors are not just in the lung, but in multiple organs. If you look at people who are recovering from the SARS-CoV-1, so the original SARS or the MERS-CoV-2 infection from 1912, the most important signs and symptoms that were left behind, hence long COVID, but not the COVID we're talking about. So SARS-CoV-1 and MERS-CoV-2, impaired diffusion capacity for carbon monoxide, alteration of exercise tolerance are the most common symptoms and signs 6 months post-discharge. And then a third or more of patients have post-traumatic stress disorder, depression, anxiety, and we know these are also symptoms in the SARS-CoV-2 infection. This is again studies done in SARS, and you understand that the virus is the same, hence some amount of extrapolation of data happened, especially in the first part of the pandemic with SARS-CoV-2. So this is one of the most robust studies, a 15-year follow-up from 2003 to 2018, and this looked at two different organs. The first is the lung, and the second is the bone. So they looked at lung interstitial changes, interstitial lung disease, and they look at hip joint MRIs and functional questionnaires. They found that pulmonary interstitial damage and functional decline caused by SARS mostly recovered. And when we say mostly recovered, they declined from 9.4% to 3.2% in the first year. And then post 15 years, they stabilized. So the residual small amount of damage left behind remained post 15 years. If you looked at the hip changes, the changes on MR on the femoral head, the decline, so the improvement happened gradually over a period of time. Bone destruction reduced from 39% to 30% in the first 2 years, and then continued gradually up to 2013, so over 11 years, and then plateaued until the last assessment in 2018. Hence, damage in most cases is partially reversible. I might as well go and say it's largely reversible, even in the SARS-CoV-1 infection. What about patients who return to hospital after recovery? So that must be a surrogate marker. This is 5 New York City hospitals where the pandemic raged over 2 years. Large number of patients in the study, about 2,800 patients. 3.6% of these patients sought emergency care after a median of 4.5 days after going home. So almost immediately after going home, 103 patients, which is 3.6%, returned to hospital, and 2% of these patients required inpatient readmission. Hence, while these are not large numbers, they are significant. 1/2 of patients who returned, be that to the emergency or got admitted, had experienced respiratory distress again. So respiratory symptoms, even during recurrence, form the large majority requiring hospitalization or coming back to the emergency. And in the patients, comparing with patients not returning for care, those seen had more of COPD and hypertension. So patients with a comorbidity of hypertension and COPD had recurrence requiring hospital visit again. These were also patients who stayed in hospital for a shorter period. So patients who stayed for 4.5 days had a greater chance of coming back to hospital as compared to those who stayed 6.7 days. The pulmonary sequelae in patients with COVID-19 was studied in this Chinese cohort of patients. So this was a short-term observational study of about 150 patients whose CT scan was evaluated. And they looked at 4 important findings on CT: ground glass opacities, fibrous stripe, bronchovascular bundle distortion, thickening of adjacent pleura, and small pleural effusions. So the first 4 are very important findings in patients with post-COVID lung disease. And you can see that the GGOs remained in about 30% of cases, but the other findings, be that the fibrous stripe, be that the bronchovascular bundle distortion, thickening of adjacent pleura, all these findings would disappear over a period of time. These patients, it was thought, should have a repeat CT early if the signs were severe. So 2 weeks after discharge might be the optimal early period. However, in the elderly patients, the high-risk group of patients, they would need a longer time to reach complete resolution. This is one of the early studied cases of COVID-19. And there are 2 different cohorts. And this is an important concept to bear in mind. These are patients who had severe disease, who were inpatients, and then a smaller number of patients who had non-severe disease and were treated at home. And it's interesting to note that in this category, this entire spectrum of patients from moderate to severe disease, about 50% of patients, so 1 out of 2 patients, would have some amount of post-acute COVID syndrome. Hence, even with mild disease, a small percentage, but a definite percentage of patients would have post-COVID syndrome. The persistent symptoms are there for you to see. I won't repeat them, but you know what these symptoms are: the fatigue, the dyspnea, the cough, and so on. However, more important in this study, 1 out of 5 patients would have imaging abnormalities left behind on follow-up, and 1 out of 10 patients would have an abnormal spirometry. So 1 out of 5 with residual lung CT changes, and 1 out of 10 would have an abnormal spirometry. This is Peter George's study on how to identify patients with post-COVID ILD. And this is the algorithm that's been used the world over. So let's spend a couple of minutes looking at this. So if you've taken care of a patient in ICU or HDU or on ward care who's had severe pneumonia, with the large deluge of cases the world saw, even severe patients have in some cases been treated on the ward. The first follow-up would be at 4 to 6 weeks. And this could be a telephonic consultation, or if the patient was well enough, a face-to-face review by the doctor or nurse. So at this juncture, you consider a new diagnosis of pulmonary embolism if the patient is still hypoxic. You liaise with the local ICU team for dedicated post-ICU follow-up, and then you have a holistic assessment. And then after 4 to 6 weeks, of these 4 to 6 weeks, so 12 weeks after discharge, the patient has to come to the hospital and will have a whole host of changes, of tests on chest X-ray, clinical assessment, history taking, looking for walk tests and oxygen saturations, spirometry, sputum sampling if relevant, echocardiogram, and so on. If these tests on your algorithm are all normal, the patient gets discharged. If the patient continues to have an abnormal chest X-ray or physiological impairment on a spirometry or a 6-minute walk test, or if there's evidence of pulmonary vascular disease, they would either get an HRCT if there's interstitial changes suspected, or a CTPA if pulmonary vascular disease is suspected. An echo would be done if it's not been done already. If this patient has interstitial lung disease, they would get followed up in the ILD service if there's one, or in the general respiratory clinic. And if they have pulmonary vascular disease, they would get followed up in the pulmonary vascular clinic, or if there is a general respiratory clinic which does this, they would get followed up in this clinic. If there's no significant ILD or pulmonary vascular disease, to account for disability, look for other diagnosis and manage accordingly. So that's your algorithm. You might want to modify this algorithm, but the basic backbone remains the same. We came out for guidance in asthma. So I've talked about lung disease in the perspective of ILD. This is post-COVID asthma, which we found in some cases. So either this was new onset asthma post-COVID, which was a minority, or pre-existing asthma has poor control post-COVID, which was the majority. So our guidance, the GINA guidance, some factors remain. The fact that people with asthma are not at an increased risk of COVID-19. So mark my words, patients with asthma are not at an increased risk of COVID-19. However, if they do end up getting COVID-19, the asthma flare-up might be more severe and control long-term might be more difficult. In COVID, patients should continue using their inhaled corticosteroid and other management as would be deemed fit in the non-COVID times. So that's important. Use of ICS actually reduces the burden of COVID, and the STOIC study showed this in not so uncertain terms. So that's about asthma. Let's again try and define the risk factors for post-acute COVID-19, so the long COVID syndrome. And this forest plot shows that multiple comorbidities in the form of Charleston Comorbidity Index, ICU stay, invasive mechanical ventilation, chronic kidney disease in the way of a reduced GFR of below 60, patients with an LDH of above 320, low lymphocytes or a high NLR ratio, and opacities on 50% or more of the X-ray are prognostic factors which might indicate long COVID. So this is the entire cohort of COVID, be it mild or be it severe. However, the severe pneumonia population, the predictors were similar, but slightly different. So worth defining. So patients with a Charleston comorbidity score of more than 3, hence large burden of comorbidity, invasive mechanical ventilation, drugs like tocilizumab or corticosteroids, raised NT-proBNP, a raised CRP, and increased lymphocytes. All these factors might indicate long COVID. This is the Italian study I mentioned to start with, and the fact that symptom persistence seems to be greater in patients who have multiple symptoms or large burden of symptoms when they had COVID. And the symptoms are similar. So if you have fatigue during acute COVID, you would have more of fatigue in post-COVID. The same with the dyspnea, the joint pain, and the chest pain. So that's something that's worth remembering. This is the wide array of extrapulmonary manifestations that you get: the dermatological, cardiac, endocrine, gastrointestinal, neurological. The list is long. There's a list of symptoms on there, and I leave this slide with you guys to read at your leisure. I have almost run out of time, but remember multiple organs that you need to look out for. The mechanism of injury in various organs. The basic is inflammation. So a couple of examples. Liver injury in COVID-19 is when the hepatocytes and cholangiocytes get affected by SARS-CoV-2. It also induces a cytokine storm. It increases the right atrial pressure and impedes venous return. And all of these factors result in liver dysfunction. Liver dysfunction results in abnormal liver enzymes, elevated free fatty acids. There's increased microvesicular steatosis, lymphocyte infiltration, and all these in the liver, portal tract and lobular calcification, and so on. So this results in liver damage. Similarly, hormonal imbalance is caused by an array of factors like SARS-CoV-2 causing decreased testosterone, low serum TSH, secondary adrenal insufficiency, decreased insulin, and all of these factors results in poor control of diabetes, insulin resistance, even hypertension, thromboembolism, and so on. The studies in cardiovascular sequelae do not show any definite data as to how acute treatment of COVID-19 may affect long-term cardiac recovery and function. However, patients with ostensibly recovered cardiac function may still be at risk of cardiomyopathy and cardiac arrhythmia. So underlines the fact that these patients need long-term follow-up for cardiovascular sequelae. And the same with neurological sequelae. This is associated with psychiatric sequelae. We've seen a lot of patients with dementia, depression, post-traumatic stress disorder, not different to what we saw in the SARS-CoV-19 infection. The long-term neurological and psychiatric sequelae need to be anticipated. Again, the patients need to be examined for this, especially the patients who are elderly, especially the patients who have comorbidities. This is looking at the psychological scoring, the post-COVID-19 functional status, or the PCFS scale as it is called. This looks at functional limitations in individuals, and they found that there was significant functional limitation in patients in the post-COVID period, more than what we found in SARS-CoV-1 or in the MERS epidemic. So these are my concluding remarks. The fact that post-COVID syndrome requires, besides symptoms, comprehensive organ damage dysfunction, and we have told you the various organs that need to be looked at. The post-COVID syndrome is not limited to severe patients. It's also true for a smaller minority of mild patients. Symptoms are mostly mild in post-COVID. They improve with time. However, there are no identified predictors. Radiological and spirometric changes are mild and are observed somewhere between 10 to 20% of cases, and the findings contribute to efficiently designing follow-ups for patients with COVID-19 in the post-COVID period, a plan that all of you should have when you see these patients in the coming years. Thank you very much for listening.
Thank you very much, dear Raja, for this excellent talk as well. We have really started to see many patients in our outpatient clinics who present with post-COVID symptoms and long COVID. So it will remain in our agenda for a long time, it seems so. So dear audience, I hope that you have enjoyed the presentations, and now it's time for the questions and answers. So actually we have a rather good time, pretty good time to discuss your questions. So Parvez and Raja is also here. I'm here. So we are welcoming your questions, and please type your questions so that we can ask them to the relevant speakers. And to start with, actually, I have a question to Parvez, if I may. Parvez, you have outlined the burden of influenza very well, and actually that is a reflection on the gains that we can have with the influenza vaccination on a broader basis. Actually, not only for vaccinating high-risk or at-risk patients, but also healthy people would do a lot in terms of benefiting from influenza and protecting the unvaccinated individuals. So my first question will be about this. So what do you think about vaccinating the healthy people as well, aside from vaccinating high-risk people with comorbidities and chronic diseases? So what are the benefits and collateral impacts of vaccinating healthy people with regards to protecting the vulnerable people in the community? This will be my first question to you, please.
So many, thank you for that question, and that is extremely important. That my talk was basically relevant to India, and in India we do not have, unfortunately, a routine Ministry of Health recommendation for influenza vaccination, which rolls out a national immunization program. And influenza does figure as one of the recommendations, but is not included in the NIP as a part of the program. That is why the physician societies are basically concentrating on people who are basically under their cover for various diseases, like chest societies talk about chronic respiratory disease patients, pregnant obstetricians talk about pregnant females, and vice versa. So it's very important that since we have a supply issue and we have and not a public funded program of national immunization for influenza, that is why people are concentrating on those who have a high risk for influenza-related complications. But what you're saying is absolutely relevant, that we must actually vaccinate anybody who is willing to take an influenza vaccine, and that not only has an effect on protecting him from getting influenza or influenza-related complications, but also has a downstream effect on preventing influenza in his community, in his neighborhood, in his home, in his relatives, and that has a definite effect. And there could be very many amongst those who could be at a high risk for developing influenza-related complications.
Yeah, great. And another question that's asked a lot actually is the co-administration of the vaccines. So you have talked about the pneumococcal vaccine and also the influenza vaccine. So and we also know the concept of not missing any opportunities for children and for the adults as well. So what will be your advices for the co-administration of pneumococcal and influenza vaccines, and even the COVID-19 vaccines? Can we administer them to the same person simultaneously at the same time, at the same visit?
Yeah, I mean, talking about influenza and pneumococcal vaccination, that has been talked about a lot in the context of chronic respiratory disease or otherwise also in people who are at risk for developing pneumonia or influenza-related complications. Yes, it can be administered at the same time and preferably at 2 different sites at the same time. And that would be an opportunity for you to ensure a greater acceptance of the vaccine, or both of the vaccines. Now, currently, we are talking of COVID vaccine. And in the context of COVID vaccine also, even though there are some bodies who say that there should be an interval of around 2 weeks between the administration of one vaccine and the other, but many societies now believe that we can administer all of these vaccines together at the same time so as to ensure a better uptake of the vaccine. You can give them together.
I think this is very important to emphasize, not to miss any patients in the hospital, in the community setting, and we can apply all these vaccines together at the same visit, not to miss any chances, because actually the risk populations are the same. So people at risk of influenza, at risk of pneumococcal disease, and risk of COVID-19 are all the same people. So we shouldn't miss any chances, I guess.
Absolutely, absolutely, yes.
Okay, thank you very much, Parvez. So I have now another question to Dr. Raja. So thanks a lot, Raja, for giving that talk, because I think people will have many questions in mind, as this is actually something new that we are facing at the moment. So we have a question saying that from Hisham Omzil: did the SARS-CoV-2 vaccination decrease the long COVID? And if so, to what extent?
Thank you, Mineya. Absolute pleasure to be here. That's a very important question, but like a lot of important questions, this probably we don't have a concrete answer till now. There have been a few studies, especially with the Moderna vaccine, and one I'm aware of with the Pfizer vaccine, where administration of the vaccine seems to have reduced the incidence of long COVID effect. However, I don't think we have got robust long-term data. I don't think we have a controlled trial where we've actually looked at population of patients who've had the vaccine and then looked at non-COVID versus people who've not had the vaccine and then looking at non-COVID. But the couple of trials that I spoke of do seem to suggest that it reduces the incidence of long COVID, especially the cardiovascular, neurological, and respiratory symptoms that happen in the long term. The fatigue, the lethargy, the myalgia, the headache, etc., the more common post-COVID symptoms, we don't have data about, but the major organs that get affected, the effects of non-COVID seem to be lesser in the vaccinated population as compared to the non-vaccinated population.
Okay, thank you very much. So actually, Raja, it's still your turn. I also have one burning question, because I face this a lot in my daily practice as an internist. So I have many patients who just come to me with cough after having contracted COVID-19. And when I do the examination, I usually find no sign of a bronchospasm, like bronchi or respiratory difficulty. But I sometimes feel it difficult to make the differential diagnosis if it's a bronchial hyperreactivity reaction or a pending asthma. So how shall we manage these patients? For example, shall we directly send them to spirometry or just follow up a little bit, put on inhaled corticosteroids? So what will be the best way to manage these patients from a cost-effective and cost-conscious way, of course, also? Thank you.
So again, a very relevant question. We see that in our practice too in India. And I think a lot of this is to do with reactive airways disease post-COVID, the so-called post-viral bronchiolitis that we've seen in children, but also in case of adults in lots of cases. Seems to happen even more with COVID. It might be because of the large number of cases that we have had during the pandemic. Now, I think you can divide these patients into 2 categories. A lot of these patients are allergic. So if you ask them about sort of allergic rhinitis in the past, a bit of cough, seasonal, which seems to happen, they would admit that they've had these symptoms in the past, even though they wouldn't stamp these as being asthma. And in these individuals, I think the fact that they've developed reactive airways disease, the diagnosis is on more sound footing. And in these individuals, I would give them a period of inhaled corticosteroid with the presumption that these people have a post-viral cough, which is related to reactive airways disease. I don't think doing a spirometry in these individuals is very useful. However, doing something like an exhaled nitric oxide, a FeNO test, or doing an IOS in these individuals looking for small airways obstruction is something that might be done. However, in most cases, the most cost-effective way would be to give them a trial of 6 weeks worth of inhaled corticosteroids at a reasonable dose. And when I say reasonable dose, I mean something like a budesonide 800. So 400 microgram twice a day would be a reasonable dose, and then bring them back to see what sort of response these individuals have. Now, in some individuals, especially with the moderate to severe category of COVID, the cough might be related to an underlying interstitial lung disease. You know, they might have a DPLD. And I think if the cough is persistent, if there's some breathlessness, if you walk these patients and they desaturate, it's a good idea to get a CT scan done and make sure that we don't have any underlying interstitial lung disease, any underlying fibrosis, which might be causing the cough, where oral steroids would probably be the way forward, unless there's fibrosis, in which case there would be an antifibrotic. So I think it would be horses for courses. It's either reactive airways disease, a post-viral bronchiolitis sort of phenomenon, or there might be more of interstitial disease, parenchymal disease, in which case you would do a CT and try and make a diagnosis before you start treatment.
Yeah, Great. So it's very important to get a thorough history and do the physical in a detailed way, and to try to get the clues in patient's history to direct us to which way we should go. Okay, thank you very much, Raja. So I have another question to Parvez now from Mudassar. So the question is, Dr. Parvez, what will be your suggestion regarding influenza diagnosis and vaccination for rural communities of developing countries?
So I think there are two questions in tandem. One is regarding the influenza vaccination. And I think there is nothing to tell about the urban communities with the rural communities. The influenza risk conditions, if they are prevalent in the urban communities, they do exist in the rural communities as well. And the influenza vaccination strategies would actually remain the same. However, for diagnosis and treatment of influenza infection, the strategies could be slightly different in the context of the thing that modalities in the rural settings. And if you do not have them, you would be guided by the seasonality of influenza in that particular region. If you have a person coming to you with an influenza-like illness or a SARI or a severe acute respiratory illness, and there is a
I think Parvez is having some difficulties with the connection.
Yes, I think move on to the next question, I think.
Have we lost him? Okay. So maybe I have several questions for Raja as well. So actually, you have shown us a guideline to see which patients are at increased risk of long COVID. But sometimes it's not so practical to just have some complicated algorithms in our daily lives and to see which patients we should follow up and which not. So in your daily practice, what's your practice? So when you discharge a COVID-19 patient from the hospital, for example, when do you just recall him or her back to the hospital for a follow-up to see whether long COVID is developing or not? And which patients do you safely discharge without a routine follow-up for the COVID-19 issue?
Sure. So, Mini, I think let's categorize the patients in a slightly different manner. Let's categorize the patients as people who are at home and are being treated at home, and patients who are admitted to hospital. So I think patients who are being treated at home, essentially the people with very mild or mild disease, are the ones who would probably need a virtual follow-up in 2 weeks' time. So we give them a virtual appointment where they can speak to a doctor and make sure that they're okay in the immediate post-COVID period. And we would bring them back to clinic once in about 6 weeks to 3 months' time to make sure that we do some basic investigation. Well, first to take a detailed history, like you said, which I thought was very relevant. So take a detailed history, make sure that none of the extrapulmonary and the pulmonary organs seem to be affected in any way. Do some basic investigations. And when I say basic investigations, I would include a chest X-ray, a spirometry, a 12-lead ECG, an echo, and some basic blood tests which look at a complete blood count, a sodium, potassium, urea, creatinine, a liver function test, and a CRP, and make sure that they are on even keel. And if they are, I don't think we need to bring them back to clinic. They need a fallback option. They need a number where they can bring up in case they have a problem going forward. And we have seen a small cohort of people, even from the Italian study, who seem to become more unwell even beyond 3 months of having mild disease. It's a very small proportion of cases, but it tells us that we need a fallback option in case people become unwell outside the 6-week window with mild and very mild disease. So that's our outpatient lot. With the inpatient lot, this is mainly people who got moderate to severe disease and patients maybe who have multiple comorbidities and get admitted because of the comorbidities getting worse, rather than having COVID pneumonia or severe COVID lung disease, which has necessitated admission. So these patients are sicker, and when they're stable enough to go home, in most cases, we would again give them an online appointment, a virtual appointment, to see us between 7 to 14 days following discharge. So when we have seen them 7 to 14 days following discharge, if they're stable, then we would bring them back to clinic in 6 weeks to 3 months, like we said. But here the assessment would be more detailed. So I would get a chest X-ray, probably a CT scan in a lot of cases. I would get a spirometry done. I would get a 6-minute walk test done. I would get a 12-lead ECG. I would get an echo done. And if any of these investigations suggest an abnormality, for instance, if this patient desaturates significantly on walking, I would have a low threshold of getting a CT pulmonary angiogram done in these patients to look for pulmonary vascular disease, for instance. So I think the algorithm would be much more detailed, and I wouldn't discharge them at first follow-up in clinic. I would give them a follow-up appointment again in 2 to 3 months' time, and I would follow them up at least for a total of 6 months from being discharged from hospital. This is obviously for the more hypoxic patients or the ones who've had uncontrolled comorbidities, which has necessitated admission. So that would be my sort of algorithm for follow-up of these patients with mild, moderate, and severe COVID.
Yeah, thank you very much. And actually, this is a new era. It's very clear. And again, it's very clear that we need to handle these patients in a multidisciplinary way. So they will have neurocognitive issues. They will have arrhythmias, not only the respiratory problems as well. So, for example, in my hospital, we have a post-COVID-19 follow-up clinic. And maybe it will also be required at some point for all hospitals to implement such a strategy to handle these patients in a multidisciplinary way in a follow-up clinic and to dedicate a specific place for them too. So do you have such polyclinics for those people?
So, yeah, I mean, so we probably have it in a slightly different structure. So we wouldn't have all the specialists sitting together in one clinic like often happens in the West. But what we would do is we'd either have a physician or a pulmonologist. So when I say physician, I mean an internist or a pulmonologist or an intensive care doctor who sees them like I described in 6 weeks' time. And when they get their basic investigations, the ones I outlined, once that gets done, they would have access to other specialties the way you described them. So they would have a neurology or a cardiology or a gastroenterology review, depending on what the requirement is, based on their symptoms, based on the clinical signs, the investigations we spoke about, and they would see the other doctors.
Yeah.
You know, in India, because it's private healthcare, all of this also costs quite a lot of money, and hence having someone to screen these patients and then go for referrals probably makes more sort of a cost-benefit equation, a ratio favorable for us as compared to sort of having a multi-specialty clinic together.
Yeah, sure, like a triage. Yeah. Okay.
So if I can say interject.
Yeah, please, Parvez.
So what Raja is speaking about is from the context of a private institution. In public institutions where I work, it is pretty much the same way. We have a long COVID clinic wherein it's primarily managed by the pulmonologist and the rehabilitation person. And whenever there is a requirement for any other specialist, he is consulted and his opinion is taken. And further course of action depends on the opinion of the relevant specialist. But generally, they are followed in the rehabilitation clinic, which is primarily managed by a pulmonologist.
Yeah. Okay. Great. So Parvez, thanks for your contribution. Would you like to wrap up with your previous response?
So I wasn't sure where I got disconnected. So the question was about the diagnosis and management
in the rural setting. Yeah. In the rural.
So for influenza vaccination, my point remains the same, that there is very little to tell apart a rural setting from an urban setting in terms of a person being at high risk for influenza and influenza-related morbidity and mortality and complications because of an influenza illness. So influenza vaccination high risk group remains the same for urban as well as for the rural setting. For diagnosis and management of influenza infection, of course, you have difficulties in rural settings in developing countries because you might not have access to newer diagnostic techniques. However, rapid diagnostic tests are available, and now I think RT-PCRs have also percolated very deep down into very peripheral settings, and they are available. Just in case they're not available, you are running in a time when you have a seasonality of influenza which has been depicted and described for your particular region, and you have encountered a patient coming with influenza-like illness or a severe acute respiratory tract infection, the SARI or ILI, and you are in an influenza season. That is the time you can give a consideration for starting a person on antiviral treatments if you are pretty convinced that they are not dealing with a bacterial infection.
Okay. Thank you. Thank you. And we have 2 questions and we have 5 minutes. So to have a quick response from you, they're again related with the post-COVID-19 syndrome. So the first one is from Naik Omkar Kesarinat. So what's the relationship between long COVID and other post-infectious syndromes? Would you like to respond to that, Raja or Parvez, if you want?
Sure. So relation between long COVID and other post-infectious syndromes, I think the question basically means, would you expect similar symptoms like post-COVID in post-influenza period, for instance? I think that's probably what the question is about, or maybe post-pneumococcal pneumonia, for instance. And I think most viral infections, moderate to severe viral infections, would result in a period where we have post-viral syndromes. So you would have a period when you have the tiredness, lethargy, the body ache, the headaches, and so on and so forth. And they have been reported in the SARS-CoV-1 pandemic from 2003, in the MERS, in the 2009 influenza pandemic. So I think all of these, we've seen these post-COVID viral, not the post-COVID, but the post-viral syndromes that we have spoken about. The degree, I think, varies to an extent. I think the deluge has been the greatest with the SARS-CoV-2, and hence the numbers that we see are flooding our clinics. This did not happen in the post-influenza or in the SARS-CoV-1 or even in the MERS pandemic because the numbers were far smaller. But I think the symptoms are very similar. The couple of studies I presented from the SARS-CoV-1, where I spoke about a resolution of interstitial lung disease in the post-COVID period, or where we spoke about the femoral neck and the femoral head and the osteoporosis that happens in the long term in these patients, they seem to resolve over a period of time, very similar to what we are seeing in the post-COVID period. So I think these are things that we will learn as we go along, but I think there's no doubt that post-infectious syndromes are something which are seen in other viral respiratory illnesses like we have seen in SARS-CoV-2.
Okay, thank you very much. So actually, thank you very much, to our distinguished speakers for being a part of this very important and current discussion on management of viral preventable diseases in the COVID-19 era and managing patients with these diseases. So it was an excellent session, and I also would like to thank to the audience for their great interest and great questions to wrap up actually the session. So now I would like to hand over to my dear colleague Farah Messoud. So she will open the discussion for the panel discussion, where we will be discussing about respiratory virus pandemic preparedness with again renowned experts and speakers from all over the world, and look forward to seeing you just in a few minutes. Thank you, dear speakers.
Thank you, Mene. Thank you so much.
Thank you.
Thank you, everyone. And look, before we go to Dr. Farah Messoud, I just need to wrap up a couple of things, a few housekeeping issues. So thank you, everyone. Sincerest thanks for everyone who participated in our first session of the 2022 Respiratory Diseases Workshop.